área se encontravam para discutir e refletir e partilhar e criar. E quando estamos a falar de meaning, e colocar aqui a expressão meaning, estamos a falar de significado, estamos a falar de encontrar aqui um espaço para nós partilharmos ideias, reflexões, técnicas sobre aquilo que são os desafios de gerar significado para todo tipo de situações, que são situações extremamente complexas na nossa sociedade e que colocam desafios aos clínicos, colocam desafios à prática e por isso se torna necessário ter este tipo de espaços em que nós possamos de facto fazer essa reflexão e essa partilha, e para isso estamos a dar como prioridade convidar grandes investigadores que trabalham na Europa, no contexto europeu. Não estamos nesta altura pelo menos a dar particular ênfase a convites de investigadores nacionais, estamos a trazer investigadores europeus e que naturalmente temos aqui o desafio da língua, porque todos estes investigadores vão apresentar em inglês. Eu sei que a generalidade dos portugueses tem facilidade em entender o inglês, e hoje trazemos a Clare Killikelly, que é canadiana de origem e é psicóloga desde 2006, formou-se no Canadá, depois foi viver para o Reino Unido, depois de estar a fazer doutoramento no Reino Unido, passa a trabalhar na Universidade de Zurique, que é uma das universidades que tem mais desenvolvido a psicologia clínica no âmbito do trauma e do luto, em particular com o trabalho do Andreas Merker, que tem sido um impulsionador, sem dúvida, nestas áreas, e que tem dinamizado muito na Europa, e devemos muito, quer na Europa, quer ao nível da OMS, e a Clare tem desenvolvido muitos trabalhos na perspectiva de desenvolvimento de instrumentos de avaliação psicológica, particularmente na área do luto. E, paralelamente a isto, e o grupo de Zurique trabalhou com a Organização Mundial de Saúde, a OMS, na perspectiva da inclusão daquilo que se chama hoje o luto prolongado na tabela de classificação de doenças, para o qual os países que fazem parte da Organização Mundial de Saúde têm o dever de avaliar e de tratar. Claro que da teoria à prática vai um longo caminho, e por isso há aqui todo um trabalho de desenvolvimento e preparação para aquilo que chamamos o ICD-11, e que parte também de desenvolvermos instrumentos que possibilitem os clínicos avaliar este tipo de situações e diagnosticar e depois tratar. Reconhecer que existem estas dificuldades, existem estes problemas associados ao luto, é importante, e medir estes problemas acaba por ser uma boa estratégia para haver este reconhecimento dos problemas associados ao luto. So, Clare, I think I presented yourself a bit, but and also I presented the topic in general concerning the ICD-11 developments for prolonged grief disorder, and then I give you the space for you to talk and to make your presentation. I want to thank you just now about for you to be here and to share with us your knowledge and your experience, and we are very honored to have you here. Thank you.
Well, thank you so much, Jose and Andrea, for inviting me. I'm actually very honored to be here, and thank you for the introduction. I think it was positive. I don't speak Portuguese except for roast beef and pastéis de nata. Okay, and good. I didn't hear any of those things, so I assume that's a good sign. Okay, so I will get started with sharing my screen. Okay, I think that's available now. Yeah, perfect. Okay. Yeah, so thank you very much. I'm really pleased to be here, and yeah, hopefully you are enjoying some sunny weather on this grief topic. I know it's maybe not the most fun for a Tuesday afternoon, but Yeah, there we are. All right. So yes, as Jose, I think, introduced, I'm Claire, and I'm currently working for the University of Zurich. I'm a group leader there, and my topic is grief and the new prolonged grief disorder and how that might look in different cultural groups. So yeah, that's my basic research remit. I'm also a clinical psychologist, and I work in my own private practice, working with people from around the world, and yeah, working also with grief and trauma. So let me see if I can get my slides. Okay, so just a brief overview of what I will be talking about today. Prolonged grief disorder, evidently, and more specifically, the excitement and challenges around a new mental health disorder. We're kind of in this special time in the field of mental health where the ICD-11 will be rolled out in clinics in January 2022, which means that we have the opportunity to observe these new mental health disorders that are included for the first time. In my area, prolonged grief disorder is one of them. So that comes with a lot of excitement, but a few challenges. And I wanted to speak to the challenges with the research that we have in this area. So before I get into the research and the kind of technical side of what I want to talk about, I'd just like to acknowledge the emotional part of this discussion and the topic of grief and prolonged grief disorder. I think all of us have experienced grief and loss in one form or another. Maybe for some of us, it's a distant memory of a grandparent, or maybe for some of us, it's a very close and raw experience still. And I'd like you to just remember that feeling, that those experiences that you had, that phenomenon of grief. And perhaps it's different for you than it was for your family member or a close friend. Perhaps there's some things about that grief that are still with you today, some things that have shifted, some things that haven't. Commonly, the individual's experience of grief is very different from each other. So we each have our own unique experience of grief. Some descriptions of this might be lost in a sea of grief. Your days are unstructured and never ending, consumed by grief, the deep wrenching sorrow of loss. And just from these kind of descriptive texts here, you can see there's actually quite a variability in the experience of grief. And what my job as a researcher and clinician is to try and capture that experience of grief in a reliable and valid way, so we can understand this clinically and assess people for treatment and support. But I also have the aim to capture the unique phenomenon of grief and everyone's unique and personal experience of grief. I think that is also a very important thing to keep in mind. So how do we do that? Well, let's see. First of all, I'd just like to clarify the difference between natural grief and a disorder of grief. And probably what most of us have experienced with grief is this natural grieving process and grief. And this contains common symptoms, cognitive, affective, and physiological symptoms such as disbelief, longing, anger, depression. These things are very common, and they tend to peak about 6 months after the loss. So you can see this graph here. About 6 months after the loss, these symptoms are the most intense. And then they gradually decrease. So about 2 years after the loss, most of these symptoms have kind of dissipated over time. When disordered grief is present, the quality and the characteristics of the symptoms aren't necessarily different. So you still have all these emotional and physiological symptoms. It's just their intensity and particularly the duration of the symptoms indicate its disordered nature, its prolonged nature. And actually, disordered grief is one of the only disorders where you're expected to suffer for a period of time. Many other mental health disorders, you hope that the person recovers as quickly as possible. But actually with grief, there's an expected period of suffering, of distress and pain that is expected for an individual to experience. However, that duration of what's normal, what's a natural grieving process, is different depending on different cultural groups and different contexts. So for example, in Germany, they have the Trauerjahr, which means an individual is expected to grieve for 12 months. And then after that time, they're expected to kind of regain their life and reclaim their life in a way. In other cultures, there's a 40-day grieving period. In some, there's a 2-year grieving period. So it's culturally linked. And that's very interesting for the work that I'm doing. So let's see next. So just a brief history of how we got to prolonged grief disorder. And if you were familiar with the field at all, you might have heard of the different terms, for example, complicated grief, traumatic grief, persistent complex bereavement disorder, which is the PCBD there. These are all previous iterations of our current prolonged grief disorder definition. And these are an important history of how we got to the current definition, but it's a bit variable, and actually still some of these definitions are currently being used in the research, which makes sometimes the consensus in the field quite difficult. So there's a challenging history of grief disorder. So how did we come up with how did the working group for the WHO come up with the newest iteration, the newest definition of prolonged grief disorder? And this new definition actually follows the WHO's newest remit, or the newest aims for the WHO, which are based on 2 things. The first is clinical utility, and the second is global applicability. And clinical utility means that the definitions of disorders that are included in the ICD-11 now have to be easily communicated, easy to use, and good for treatment planning. So they have to fit those criteria. And in order to develop the PGD criteria, they did professional surveys and they did field studies looking at how useful are the definitions in the clinic. So that was their main aim, first main aim. The second main aim was global applicability. And this meant that the diagnostic or the definition features, they had to fit with different cultural groups, different social, religious demographics. Currently, there's guidance on how this should be achieved, but there's actually no more information yet. And that's the research that I'm doing at the University of Zurich. So how can we apply these ICD-11 definitions around the world in a global context? And just to say that, so the results of the clinical utility field studies and surveys were 2 core symptoms of grief, a series of accessory symptoms, so examples of emotional distress, impairment and time criteria, and sociocultural norms must be included. So what does that look like? So here is the newest and current definition of prolonged grief disorder for the ICD-11. And you can see it has all these clinically useful items in it as defined by the WHO. But interestingly, they contain criterion E, which is cultural features. And this is a newly included criterion in the ICD-11, which means that the distress has to be beyond what is expected in that cultural group. So it has to violate the norms of that cultural group for the amount of pain, the amount of suffering, the duration of distress. It has to be atypically long based on that cultural group. So it's an ambitious criteria there, but how to operationalize that is still another issue. So okay. This graph is a bit backwards, but on the left side is 2001, and then on the far right side is 1996, if you can't see. So this is basically to show that, it's an exciting time in the field, that there are increasing. So in the past 25 years, the number of publications on prolonged grief disorder has kind of multiplied. And I'm hoping that number goes up this year a little bit more as well. We're not having a slump, but I think there's still research coming up. So it's an exciting time in the field, but there's challenges. So at the moment, I see 4 main challenges for the introduction of the new mental health disorder, prolonged grief disorder. And the first and probably the most pertinent, at least from a research point of view, are these scientific gaps. So there's, a number of areas where there's some weakness in research in prolonged grief disorder, and I'll talk about two of those next. At the moment, there's also societal urgency. So, with the refugee crisis a few years ago, of course, everything's been foreshadowed by the COVID-19 pandemic. That is something that a lot of grief researchers are concerned about, and clinicians as well. The number of deaths, and particularly the traumatic nature of the deaths, means that we could possibly see an increase in prolonged grief disorder cases. So far, it hasn't been the case yet, but research is developing. The other areas such as stigmatization, pathologization, and the clinical need for change. So these are all kind of challenges that are coming with this new disorder. Okay, so I would like to focus on two challenges that my research has tried to understand a little bit more, or at least provide some opportunities. And this is establishing the psychometric validity of these ICD-11, of the ICD-11 definition, which means, are we measuring what we think we're measuring around the world with this definition of grief? And the second challenge is establishing the global applicability. So can we include unique culturally specific symptoms and grief within the ICD-11 definition, and how could we possibly do that? So those are the things I want to explore in more detail. So the first challenge is establishing the validity of the prolonged grief disorder definition. And currently, the main challenge with that is that the definition that is included in the ICD-11 is based on criteria from 2009 and evidence and research from based on this definition, but it's actually not on the current definition. So different definitions of grief and this disorder are being used. So for example, here you can see the 2009 criteria, the DSM criteria that's currently being used, and then finally the newest ICD-11 criteria. And although they're all disorders of grief, they actually differ significantly in the number of items that are required for a diagnosis, the core items that are featured, the number of months that must have passed in order for a diagnosis to be given. So there's some significant differences in how these definitions are presented. And at the moment, all of these definitions are still being used in the field. So it's really difficult to have a consensus in research and to explore, for example, the prevalence of prolonged grief disorder, because they're using different criteria. So that takes us to the prevalence crisis, I call it, which is where we find that in particular groups of people, we find elevated grief symptoms, and it's not clear why. So here we did a scoping review of papers that looked at grief, prolonged grief disorder in Asian communities. And we consistently find that the rates of disorder are about 5 to 25% higher than what we would find in the global north or the kind of Western European population. So usually in a Western European population, you find rates of disordered grief about 10%. But here in these Asian groups, mostly Chinese, it's much higher than that. And at the moment, it's not clear why. So there's a few explanations, but you can see also that they use different criteria. Some of them use that 2009 criteria, some of them use the current ICD, and some of them use complicated grief. So there's this kind of mix and matching that's happening in the field. Okay, so why would we find such high prevalence rates in these Chinese samples? One could be, as I just said, we're using all these different diagnostic tests, and this is leading to different rates of prolonged grief disorder. Some of them are more strict than others and more sensitive than others. So the second hypothesis could be that the criteria that we're using are not actually adequately capturing the specific nature of grief in these Chinese populations. So it could be that we're missing out on particular symptoms that mean that we're overdiagnosing some of these grief symptoms. So what's the solution? Well, develop cultural supplements. The third hypothesis could be that there truly are higher rates of prolonged grief disorder in these different communities. And what can we do? We could test our underlying structure there. So I'm going to focus on these first two hypotheses and think about how we could explore that. And then the third hypothesis will be the next adventure that we go on in our research journey. Okay, so the International Prolonged Grief Disorder Scale is a scale that we developed at the University of Zurich that seeks to both capture validly and reliably the ICD-11 criteria specifically, while at the same time preserving these unique individual symptoms of grief that people might experience and culturally linked symptoms of grief. So it's a scale made up of two parts. The first part we call the standard scale, and this is really based on the ICD-11 criteria. So it's really a basic assessment of those items included in the ICD-11. And this is what you would use in the clinic for establishing a diagnosis. The second part of the scale we call the cultural supplement. And this is kind of accessory symptoms that are not covered by the first scale. And they're culturally specific and a kind of a huge range of possibly culturally based symptoms, kind of catalog of symptoms that are found around the world related to grief. And this cultural supplement, we envision it as something we could use for treatment planning and for further exploration of a diagnosis. So when you have a question about diagnosis, or maybe you're not fully capturing that person's experience, this supplement might help clarify certain questions in a diagnosis, or at least in treatment planning. So yeah, it's both a catalog of symptoms, but also a method for how you might develop your own culturally specific supplement for assessing grief. And I'll talk about how we did that with refugees in a second. So just to say, our first investigations of the psychometric properties of the IPGDS are strong, so it has good reliability, and the criterion validity is also in the right direction, meaning that when we expect there to be more prolonged grief disorder, like in violent loss, we do see higher rates of prolonged grief disorder. So except in this strange Swiss sample, which I don't have an explanation for yet, but let's see. Okay, so using this new ICD-11 scale, IPGDS, we also have this problem where the ICD-11 hasn't officially defined thresholds for a diagnosis, which means that we're kind of left to our own clinical experience and judgment to define specifically when a diagnosis is met. Here I have listed this kind of strict, moderate, and then the Mesijuski criteria, which is a criteria that's been used since 2016. And they're all slightly different, which is, again, a bit frustrating in the field. So yeah, the strict, to meet the strict criteria for diagnosis, you have to score 4 or above. For the moderate, 3 or above. And then for the Mesijuski, it's 4 or above again, but there's no impairment criteria, and there's 3 to 5 accessory items. So again, just to say, there's variability in how a diagnosis is being made, even when we do have this new ICD-11 criteria that is supposed to be a consensus. Okay, so, and this is a problem in the field, because actually this is data from Jose, and when we look at the strict, moderate, or Mesijuski criteria, we can see in the Portuguese sample here, there's a lot of variability, and these are statistically significantly different. So the strict criteria, 6.9% of people would meet a diagnosis of grief. In the moderate, almost 30%, and in the Mesijuski, 23.4%. So there's a lot of variability there within a population, within a sample, but also between. So the Chinese participants, again, are found to have as elevated prevalence rates across all the diagnostic criteria, and there's differences between within the diagnostic criteria as well. So it's a problem in the field, and at the moment there is not a consensus on what thresholds should be used. So yeah, it's a question. Okay, so those are the challenges that we've been faced with using this new ICD-11 criteria in terms of the validity and establishing that in these different groups. The second big challenge that we faced is this global applicability. So what do I mean by that? So in different cultural groups, the way that pain and suffering is expressed and experienced can be very different. And this is also true with grief. So you can imagine in trauma or even in depression. So the symptoms that somebody might express can be linked to their context, their culture, their gender, their understanding of illness. So cultural concepts of distress are the ways that cultural groups experience, understand, and communicate suffering. And this directly impacts how the illness is expressed. So, for example, these are some examples we found doing a kind of systematic review of grief expression in refugee context. So here, the first one is in Cambodia, and it's Nuk Shrunu, and this means to recall with nostalgic longing, which is very close to our understanding of yearning and longing for someone, but it's slightly different. So if we ask a Cambodian refugee about yearning, they might not answer in the same way as if we asked about Nuk Shrunu, for example. Imitating the deceased behavior is quite common in some Iraqi Kurdish groups. And actually, if they were to be assessed by a Western psychiatrist, maybe it would ask questions about psychosis or kind of this kind of strange behavior, whereas actually it's quite normal in their cultural context. Dukkha Sita is the kind of Papua New Guinea experience of a diminished sense of identity. And although we do ask questions about losing a part of oneself in these questionnaires, a diminished sense of identity in this context means kind of more globally about their whole life experience, almost close to depression. And we don't ask about that in our questionnaire. So there are some kind of unique grief expressions that we're not necessarily capturing with the ICD-11 scale. So how can we do that? And the other thing is, so there's these symptom items that perhaps need to be adapted or adjusted in different cultural groups, but the whole assessment of mental health is a culture in itself. So the fact that we go to a clinic, we have pain, we have suffering, we go to a medical professional and we get a prescription for a treatment. That is a cultural script that we're familiar with in the global north, but actually in many cultures, that's not how pain and suffering is treated or experienced or planned. So many people would go, especially with grief. I think this is really important with grief because it is seen to be a very natural process. And perhaps the first port of call would be a priest or a religious leader in many communities, or a family member. So it's not necessarily instinctive that we would go to a medical professional when we're grieving. So doing a clinical assessment of grief comes with these challenges of we might not be assessing the right symptoms from a cultural group, and the fact that we're even assessing that might have various barriers such as stigmatization and pathologization of grief that we're not accounting for when we assume this kind of clinical assessment culture. Yeah, so it's we can get actually better outcomes when there's this cultural congruity between the clinician and the patient. when they're both aligned about their illness beliefs and they have the same kind of understanding of illness and their experience. They're more likely to have better outcomes, when they're aligned. Okay, so now I'd like to talk about a case example of how we developed this cultural supplement for Syrian refugees. And the first, so this is kind of an example of how a researcher or even a clinic might take the prolonged grief disorder scale and have the first standard scale for, diagnosis and assessment, but then the supplement could be developed and used for the particular context of that clinic and the particular individuals or groups that are coming into that clinic that might need a bit more information for treatment planning. So the first thing we did was really embrace this bottom-up qualitative approach. And we did key informant interviews with a range of different cultural groups. So we did it with German-speaking healthcare workers, with Chinese, with Japanese, and with Syrian key informants. And we got a long list of rainbow of possible grief symptoms. And then, we kind of included as much as we could just to keep as much of the variability in grief experiences in these symptom items. So we also asked, so the surface level was the specific symptoms, and the second level was looking at what I'm talking about in terms of kind of barriers to acceptance of a prolonged grief disorder, the stigma around that, and kind of different ideas of what mental illness means in different groups. So we also asked about that. The second step, so we had this big long list across different cultural groups of all possible types of symptoms that people could experience with grief. And then we did in-depth interviews with Syrian refugees themselves, and we kind of asked specifically about the items that we already had, but we asked them to add anything or kind of talk about their own experience of grief in detail, so we could pull out more information on grief. And what we found was there was some really important items that were missing still, of course, related to the refugee experience. So this is a kind of unique experience where the individual is grieving perhaps the loss of a loved one, but also the loss of a homeland, and also things like ambiguous loss where the person they love is missing. They don't know. There's uncertainty about the death of that person or not. So we kind of had this big map of all the other possible symptoms related to being a refugee. And we also kind of had a third, this kind of 3-level model that we developed, which explored how grief is shaped by many different levels in society. So there's the individual symptoms, there's the interpersonal context, and then there's the level of culture and society. And this is from Andreas Merker, the social interpersonal model. And he used it for PTSD, and we applied it for grief here. Just to say that we discovered it wasn't as simple as just adding a few more items to our list. There's actually this huge context of grief in these different levels of society that were being, we might be missing. So for example, gender norms. So it was expected that some women should grieve openly and cry and be very, very emotional and loud with their grief, whereas men were expected to not show their grief at all. And of course, this is going to affect your clinical assessment. If you're asking, are you feeling sad? Are you, how are you grieving? And the response is grieving a lot and grieving very little. It could be because that's what's expected in terms of their gender. So it's a complicated picture, but I'll go on to the next bit. Okay. And for example, we added new items to our catalog, which is such as I'm preoccupied with thoughts about those left behind. It's related to ambiguous loss. So when you don't know if a person is dead or alive still. We added somatic symptoms. So I experienced strong physical problems like headache, loss of appetite, and post-migration stretches such as uncertainty about my residency status has worsened my grief, things like that. So, for example, okay, the third step we did was we then took all these items that we gathered from the interviews with Syrian refugees, and we further developed them in focus groups with healthcare workers. So we had 2 focus groups with what we call cultural brokers. So people who, so for example, a Syrian doctor working in Switzerland. So we had both the cultural experience of being Syrian and then the medical experience of working in Switzerland. So could speak to both experiences. And yeah, we asked them about the content of the items that we had and clarification on the process and how would it work in their clinic. So kind of in-depth focus groups. And then we took this next version and we did translation and back translation into Arabic. And we did these kind of pre-testing of the questions with cognitive interviews, which we asked six additional Syrian refugees to kind of pre-test and think out loud their answers to each of the responses, just to ensure that we were actually asking what we thought we were asking. Yeah, so that resulted in step 4, which we call the Grief Assessment Toolbox for refugees. And this is a combination of, four questionnaires. So the 2 that I spoke about, the basic standard International Prolonged Grief Disorder Scale of the ICD-11, the cultural supplement that we adapted for Syrian refugees. We also developed this ambiguous loss scale, which we haven't tested yet in psychometrically, and the adjustment impact grief scale, which we also haven't tested yet. We also included this grief and bereavement cultural interview from Gerrit Schmid from ARC Center 45. And yeah, so the results are all there. We just have to put it together. But yeah, as I showed before, we assessed the IPGDS, the cultural supplement, in 121 migrants, and we found good reliability. Yeah, okay, so as a summary for what I've been speaking about. So the first challenge, in terms of my research at least, of this new ICD-11 is establishing the psychometric validity of these new criteria. And so currently there's many different definitions of grief being used, many different diagnostic algorithms. And this means that we're finding different prevalence rates within a group, within a community or culture, and between cultures. And that's causing a lot of discrepancies in the field. We don't have a consensus. So I would suggest the opportunity now is to use the new IPGD scale based on the current ICD-11 definition and use this as a kind of standard scale for the ICD-11 criteria, if that's what we want to study. The second challenge is establishing these kind of culturally relevant and culturally specific symptoms. So as I've spoken about, different cultural groups may have strong culturally linked symptoms that we're not picking up on with the ICD-11. So as much as it might be quite difficult to include these symptoms in terms of a diagnosis, although that's important, we would have the standard scale for a diagnosis, but then the in-depth assessment with the cultural supplement, for example, would give us more information for treatment planning and some aspects of a diagnosis. So if, for example, the person is saying they're seeing dead bodies in the room, we want to make sure that that is something related to their culture and grief, and maybe not psychosis, right? If we start thinking that that's psychosis, maybe they get prescribed medication and it's a whole storm of misdiagnosis, when it could be that that's how they describe their yearning and longing for their loved ones. Okay, yeah. And then I talked about the case example of how we developed the cultural supplement for Syrian refugees in our research group. Yeah, so the next steps might be for other groups to develop their own cultural supplement for their communities that they're working with and pull from this catalog of possible symptoms that we've developed. Okay, so now I think I still have a couple of minutes Yeah, so I'll talk briefly about what we're doing next, and then of course open to questions. Yeah. Okay, so we have this grief assessment toolbox, which is those 4 scales that I showed, and what we want to do next is see, is this feasible to use in the clinical environment? So we have planned a study in Canada, in Switzerland, and in the Netherlands to test these items in these 3 different groups to see, okay, is it actually feasible to use all these scales, or do we need to shorten it? Do we need to kind of make it more brief? Are we capturing what we think we're capturing with this grief assessment toolbox? So that's the next step for that. And then we've also developed a mobile app based on the ICD-11 criteria, the IPGDS, and we've called it MGAGE, which is quite long, but Mobile Grief Assessment Guide and e-resource, because it has the symptoms of the ICD-11, but we've also included, for example, a diary function and recommendations for where to get support. And we kind of envision maybe in the future, we could also include some elements of an intervention, or how to support an individual if they're indicating like high stress or high anxiety, some relaxation exercises or things like that we could also incorporate into that. So at the moment it's in German, and we've done a preliminary pilot study, 25 participants, and we actually found not only was it feasible for use, so they used it for 3 weeks and tracked their symptoms every day for a week, and yeah, we found that they did that and they enjoyed doing it. They found it easy to use, but they also had an improvement in their grief symptoms. So we found that was statistically significant at the end. Those who completed the kind of tracking their symptoms for that time had less grief symptoms at the end. So there could be something about that self-monitoring process that is really helpful in understanding and improving grief symptoms. So that's, we're going to take that. My PhD student Anais is going to further develop this for her PhD and include some elements of an intervention by kind of going back to the field and interviewing refugees alongside the Red Cross in Bern, and develop some intervention aspects as well. So therapeutic aspects. So that's all from my side at the moment. This is a bit of an old picture, but yes, this is I want to thank my students and team from the University of Zurich, and I'm looking forward to the next steps. I'm currently at the University of Mainz doing a collaboration here and thinking about this kind of intervention, online intervention aspect of this mobile app. So keep you updated.
Fantastic, Claire. I loved your presentation, the way you presented such a complex issue, and in depth the complexities of cultural influences on grief. Mm-hmm. I think the first experiences we had using assessment here in Portugal with grief and traumatic stress, we found that the usual cutoff scores published for ICG, which was probably the first main assessment scale for complicated grief by the American team. Mm-hmm. And what we found is that the cutoff score included for Portuguese a lot of false positives. Mm-hmm. We had a persistent value on the frequency of complicated grief, which was really very high. So at that time, we tried to develop an interview, a standard interview to make a diagnosis and to define which would be the cutoff score. Mm-hmm. And I don't know if it is more about the language, in fact, that sometimes the intensity of the expression may change with the use of some verbs, of some adjectives for the emotional states that may change. But consistently in for traumatic stress and for complicated grief at that time. Our cutoff scores were higher than the American ones, and those that were calculated also for other countries. I remember from South Korea, the cutoff score was very low, and the Portuguese one was a bit higher. So what was really considered complicated grief or prolonged grief disorder was really different in terms of the intensity of the symptoms. People just the way they pick they choose in the Likert scale was a bit different from Portugal than in other countries. So we tried to make that mix strategy to develop the scale, to translate, and then to define what's the cutoff, really to understand the clinical value. And that was a good strategy for trying to avoid the very high values of frequency of complicated grief, which was really strange. We had samples with 30%, something like that, which was really high. Even with PTSD, we found the same effect. Another comment about the retest on the online. I loved your online app. Good for your student for developing such good and possible to use for patients. Well, I am not sure if there is a therapeutic effect, but there is a writing effect. We know that writing is good for several mental health issues, but also the retest, using the same the retest effect. Usually there is a BA's result considering the reducing the kind of response people give to the values. But very good. I loved your presentation. I have a question considering DSM and ICD-11, and it's from Sandra, and Sandra is asking if you agree that DSM has been used more for more on research, and probably the ICD-11 will be more used on the clinical settings. Or do you envisage in some way that in the future ICD-11 may be the new consensus, both on the research and the clinical side? I don't know your experience.
Well, depends who you ask, I think. So, I'm from North America, originally from Canada, and there the DSM is used more frequently than the ICD in clinics, in clinical settings. But here in Europe, at least with Professor Merker, he is very adamant that the ICD-11 will be and should be used in Europe and around the world. So, I think, well, actually, to update in terms of grief, so prolonged grief disorder is now in the ICD-11, but it will also be in the latest revision of the DSM. So that's good news in terms of having this kind of consistency in the field and around the world of these definitions of grief. So as far as I know, I last looked at it this time last year, I think, with Holly Pregerson. They were talking about how to include the cultural features, and so we were thinking of how to do that for the DSM as well. But as far as I know, the prolonged grief disorder should be included in the next revision of the DSM. So
good news. And there is work going on making consistent criteria for both. No.
There is. I mean, a lot of work has happened in the last year, looking at the diagnostic algorithms and trying to determine what is the most reliable and what is the most sensitive, specific algorithm to use. And I think in our paper, Jose, we did just to follow up on your comments as well, we did a ROC analysis to look at the sensitivity specificity curve in your Portuguese data, in the Israeli data, Irish data, Swiss and Chinese data. And we found different cutoff scores for every group, of course. But the Chinese, I think they were all within the same line. I can't remember exactly. I think I have it somewhere on my computer. But the Chinese data, the cutoff score was much higher. So yeah, there is this variability in cutoff scores based on these different groups. So yeah, it's something definitely to pay attention to. And I think if we say, like in the Swiss data, it was for the IPGDS, it was 37.5. And that meant if you had a score higher than that, you were most likely in a prolonged grief disorder situation. But for the Chinese data, it was like 47.2 or something. So yeah, it means we have to be careful how we go next.
Yes.
What we advise, yeah.
I would assume that categorization or what would be complicated or prolonged grief is not probably the most important issue, considering the scale use. You can do a lot of research. You can do a lot of assessment to evaluate what's happening with your patients, and also to understand the variability and which symptoms are higher. It's a more inter-scale assessment, and there are some qualitative issues that they will be important also, because with the overall scale you have the whole variations that we may have, and we can do predictive research and a lot of and comparing groups and things like that. And I really think IPGDS will be a strong instrument in the use of both on the research and clinical side. And well,
yeah, hopefully.
Yes.
Let's see if
we
I
are
can.
trying to do that. And I think the nature of the experience that we have today, considering the DSM and even considering the Ollie Briggerson experience, Ollie Briggerson as I think she's not so related with clinical settings, is more sociological point of view, but in her background. So probably we have more sensitivity to some cultural, some individual differences. That's something, when we do assessment, we are not trying to reduce a person suffering to a number, but it's a way to recognize the overall suffering, that it's not simplifying too much, but it is a way to recognize the variations that there are.
Yeah, definitely.
I enjoy a lot this perspective, so that's really good to understand in depth what is happening, in fact. And also I want to congratulate you for the European perspective of joining several countries in the bereavement network, and which is also good. People communicate between them. But I have another question, considering what kind of professional background do you think would be the appropriate or the best one, or if there is a competence issue concerning grief assessment?
Well, yeah, I think that's an important question, because ultimately in the clinic, but it's not only in the clinic, so not only with psychiatrists or psychologists, but grief is present in many different aspects or parts of society. And I think it's important to help kind of lay persons or non-mental health experts to have access to information about prolonged grief disorder, because for example, clergy, a person coming to their priest with severe grief, maybe the clergy doesn't know that there is support for this kind of extreme distress and there are treatments available. So I think something that's accessible and can be used by many different parts of society, so not just experts, but teachers and kind of members of the community, and especially the grief movement is really a kind of grassroots movement. So a lot of the organizations are volunteer organizations supporting people. So I think making it accessible across the board and providing information about assessment, but then also the next steps. So we've thought about this kind of 3-tiered model. And I think with the cost proposal, Jose, that you were involved in as well, that was our kind of European idea, was to have these 3 different levels of how people could access support. Let's see where it goes.
Yes, with several layers, more on raising awareness, screening, detecting which risks that are in society, then addressing to another layer, kind of step care approach. Another layer more with more competence, more that can make diagnosis and make some special support, and then the more differentiating level for very specific cases with very high difficulties.
Exactly.
Last question: considering traumatic stress assessment and grief assessment, they should be included together, they shouldn't be?
I mean, that's an important question. So the relationship between grief and trauma, I think they're considered near neighbors or kind of sisters in the clinical world. But I think in particular groups, like the groups I work with refugees, they come hand in hand. So you have traumatic grief often. So that's grief that's occurred in a very violent, sudden, and extremely difficult circumstances. And there you have both symptoms of grief, so the yearning, the longing, and the emotional distress that comes with that, but also symptoms of trauma. And trauma is similar, but it's not the same. So there are 2 distinct disorders and 2 distinct symptom patterns. And trauma includes anxiety and fear, and also kind of memory disorder, and intrusive thoughts and all these things. And there can be overlap, but there's distinction as well. And it means that treatment is complicated because they will maybe peak and fall at different times and in different ways, and sometimes kind of cross over. So you're working on trauma and the maybe doing an exposure or thinking about kind of in-depth reliving of the trauma. And then the person comes with extreme grief and they're kind of almost stuck completely in their grief. So there's actually some new research now looking at traumatic grief, and Gerrit Schmid, they've had the traumatic grief inventory with Paul Bolin as well, and it's kind of meant to capture this dual experience. I've developed this based on our work with refugees and kind of thinking about how do we incorporate all of these experiences that refugees have. So the grief, the trauma, the ambiguous loss, the missing their homeland, and then the post-migration living difficulties. So this formulation, we don't have to go into all of it now, I think we're over as well. But kind of a map that a clinician could use with the client to identify what do we need to focus on right now? What are the goals that this person has? How are they scoring on these different measures that we have? What is highest at the moment? And where do we need to focus our treatment planning? So it's kind of incorporating all these things to try and support an individual who's experiencing trauma and grief.
Okay, fantastic. I don't know, I will open to any question that the participants may have. We have already 1 hour and 1 minute, 2 minutes now from the beginning of this webinar, but I will ask in Portuguese, if is it okay for you. Se alguém quiser colocar alguma questão, se puder colocar no chat, era ótimo, ou se quiserem colocar de viva voz também podem dizer. Se não, vamos dar por terminado. Esta apresentação vai ser depois colocada online e o André Moreira, que tem sido absolutamente fantástico, e é aqui quem tem sido extraordinário em levar estes webinars para todos vocês. É graças a eles que estamos, graças a ele que estamos aqui todos juntos. Depois vai partilhar esse link com todos vocês, para poderem ver a apresentação, mas depois também o contacto com a Clare Killikelly é muito fácil. Se quiserem, podem escrever também para tirar algumas dúvidas, algumas questões. Entretanto, não há questões?
I do have a question.
Okay.
I like the app idea very much, and I'm wondering what were the improvements in symptoms that you were able to observe, and if you have any plans to translate it to English and maybe Portuguese. Maybe you can cooperate a bit.
Yeah. So I mean, it was the sum score. So we measured grief at T1, and then time 1 pre using the app, and then time 2 post using the app. And we used the ICG measure and the IPGDS, and then for 3 weeks they filled out the IPGDS. So we had both, and so we found that the sum score decreased, so the severity of grief decreased for both the grief measures that we used at post T2. So there wasn't a specific symptom. Maybe there was. I haven't looked at the analysis yet in that way. But yeah, that could be interesting. If you want the data and you have some time, I can send you it.
I would like it very much.
Okay, great. Yeah, and plans for the next step. Yeah, I think translating it into different languages would be fantastic. I'd love to do that. And yeah, if there's opportunities to think about that. We do have everything originally in English. It's just we haven't put it into the app yet. So that could be possible then from English to Portuguese, maybe more feasible than German.
Yeah, I think it might be useful, especially now in this pandemic era, you know, because since the therapeutic and clinical aspect is very much online now, or it has, you know, sometimes it's in person, sometimes online, but it might be important to use as kind of a homework for patients to have a better improvement outside of the clinical aspect, and I think it will be very important. So yeah, please send me the data.
Okay,
I would love to see it.
Yeah, we asked the standards questions, but then we also asked people to fill out the cultural supplement and then indicate which of those items was pertinent or most important for them. So the kind of an idiosyncratic or their own individual item, we asked them to fill that out as well. And I just haven't had a chance to look at the data. So there is data there if anybody is bored and wants to do some analysis.
It's not boring. It's very interesting.
Great.
You like that kind of things. And very good, fantastic.
Great.
Great to have your question also. And those instruments are translated and adapted to Portuguese also. That would be good. The raw instruments, the items are translated, would be quite easy to do this adaptation. Good, fantastic. Claire, thank you very much. It was a pleasure. It was very good, very informative, very clear, and we are very happy to have this experience with you. And I also want to thank all people that are online, and we will share the link of the video for you and others that have not been present but wanted to be. Thank you all.
Great.
Bye.
Thank you so much, Jose. Thank you, everyone.
Bye.
Thank you.